It'll be 30 seconds before we're actually live. And then also one thing I wanted to mention to you earlier was there is a slight delay that you as a presenter, me as kind of the moderator, will feel with the audience. So if you throw out for questions, for instance, it may be like 60 seconds before there's actually like a reaction to that, if that makes sense.
Oh, okay. Yep.
So that's a little bit quirky, but other than that, things should kind of run smoothly here.
Great.
So I'll start the broadcast. I'll introduce you, and then let you take it from there.
Sounds good.
Good morning, everyone, and thank you so much for being with us today. We really appreciate you taking your time out of your busy schedules at your facilities and in your jobs to join us. But we have an exciting presentation, one that I think will be super exciting and informative to everyone joining us, and hopefully very useful as we look to play golf, teach golf, and work a sometimes physically laboring job long into our career. So I'm very excited to have with us today Dr. Roufaiel, originally from New York City, has recently moved down to Jupiter to be the owner and chief physician at the Advanced Pain Management and Wellness Center in Jupiter. He's double board certified in interventional pain management, and he specializes in advanced minimally invasive techniques for chronic low back pain and leg pain. So without further ado, I'm going to toss it over to Dr. Roufaiel, who has an exciting presentation for us today. Thank you for being with us.
Hi, everybody. I'm David Roufaiel. Thanks for having me here. I'm honored to have a chance to speak with you about what I think is a very important topic. And what I want to be able to do is educate everybody here about what's new out there in the treatment of back pain and joint pain and all types of pain, other than what's been done before, kind of the evolution of chronic pain management and acute pain management, and the new minimally invasive techniques. No longer do we have to go and have a couple of steroid injections, physical therapy, and then big invasive surgery. There's a lot we can do. And right here, before I get started, just thank you, Jackie, for getting this set up, and my good friend who's a member with you, Bill Plotkin, for recommending that I do this. I'm very excited to get this going. So let me just try to share my screen here. Okay. All right, so I think it's being shared now. So we're going to get going with our presentation here. Jackie, come on and let me know if you can't see me. So I think I want everybody to know. You can see me?
Yep, looking good. Thank you.
Okay, all right. Nobody's paying me to do this. This is purely educational. I just want everybody to get this information. I think it's important, as caregivers, that we have a chance to educate people so that you can kind of take control of your own care if you really know what's out there. So we're going to talk a little bit about, classic pain management before we get into the new advanced therapies. I want everybody to really understand, what we do and why we do it. I feel too often we're rushed through these medical visits because, doctors don't have time, people don't have time. to really explain what we're doing and why we're doing it. And this will give us a little chance to talk about it. We're going to talk about a few different medications that are used and opioids, because that's a big problem, especially here in Florida, as you know, everybody is probably well aware. And then a big question, that I get very often: what is spinal stenosis? Okay, everybody's heard the term, but really, what is it? And why do we have it, and what does it mean? We're going to talk about some basic interventional techniques, and then we'll go into our advanced therapies here. So we now recognize in the medical field pain as a vital sign, okay? When you go into a doctor's office, you've probably seen these happy faces or sad faces or angry faces talking about how much pain you have. We care about it just as much as your blood pressure and your heart rate and your oxygen saturation and your height and weight. It's very important, and we finally started to acknowledge the importance of pain, in our daily life. We have many, many different ways to treat all different kinds of pain, not just medication and not just surgery. There's nerve blocks and steroid injections, multiple surgical techniques, and there's also implantable devices that we have to help treat pain. We're going to kind of briefly touch on all of it, or as much as I can today. So let's start talking about opioids first, because this is important. Okay, I'm sure many people here either have used opioids for one reason or another, or know somebody who has had to be on opioids for one reason or another. Okay, and opioids are dangerous medications. They're not meant to be taken lightly. Okay, but there is use for them. All right, and when we talk about the opioid crisis, there's documentaries, out there. Many of you have probably seen them. They're on Netflix or whatever, you use to watch things, okay? It really started around 1985. And the reason why it started was back then, obviously, it wasn't easy to look up research and look up literature. So there was actually a doctor who I ended up training with him. He wrote a letter to the editor to the New England Journal of Medicine. It was an opinion piece around 1985. In his experience, he thought that opioids were not addictive in the treatment of chronic pain, and it was a safe use, okay? And this was purely his opinion. It was a letter to the editor in the New England Journal of Medicine, and these big pharma companies went with it and started quoting it as medical research. And Pfizer started going to doctor's office talking about these studies that saying opioids were safe and everybody should be on opioids for any small amount of pain. And they started pushing them right then. And as you can see right from that point on, the opioid prescription use and the mortality rates with opioids started exploding, okay? And it's still a problem today. So everybody's afraid of opioids, right? But is it safe? Is the real question. And when used for the right indications, the answer is yes. And those right indications are generally acute pain, which is pain that's generally lasting less than 6 weeks to 2 months. For example, post-surgical pain, or, if you hurt yourself, you guys are athletes. So, if you hurt yourself out on the golf course, if you tear something, okay, and you need pain medication for a short period of time, we find that addiction is actually rather rare, and that's a question that I get quite often. The other side of that is for cancer-related pain, and opioid therapy has been shown to be effective when we're talking about cancer-related pain. Okay, for chronic pain that's not related to cancer, the addiction risk is rather high, and there's really no good evidence that is out there that shows that it actually really helps in the long term. So that's when we really try. It's this chronic pain that's really what we're aiming to treat here with non-opioid therapy. And that's why we've been developing these more advanced techniques, okay? The main issues with opioids, okay, if you're on them chronically, your body develops tolerance. It's a natural physical reaction to being on these medications for a long time, where your body requires more and more medication to produce the same effects, okay? And with tolerance comes physical dependence, meaning if you stop them abruptly, you will feel symptoms of withdrawal. And that's different than addiction, okay? That's physical dependence and tolerance are your body's physical reaction. Addiction, on the other hand, is going and using them inappropriately, like trying to crush them or snort them or inject them. Diversion becomes a problem where people have a slew of pain medication and give it to their friends because they're in pain without realizing it could be dangerous because not everybody can handle the same doses. Okay, and they have side effects. Okay, like any medication, opioids in the long term will reduce your bone density. It makes you more prone to have fractures. They reduce your muscle mass. Okay, so in general, opioids in the long term aren't that great. All right. So let's start getting into the different types of interventional management. Okay, we're going to start out really basic because I feel like, at least in my practice, I've noticed that when people are talking about having epidural injections or facet injections or ablations, which many of you may have heard of, they don't really know what they're getting or why they're getting it, other than it's supposed to help their pain. And so I'm going to try to educate us on this a little bit before we go into our minimally invasive, techniques. Okay, spinal stenosis. This is one of the biggest points of this presentation. Okay, what is it? All right. I mean, this question I get every day, multiple times. All right. I was told I have spinal stenosis. I don't know what it is, but I know I have it. Okay, and there are many different kinds of spinal stenosis. Okay, so let me just kind of get out of this so you can see my pointer. Okay, so I kind of describe spinal stenosis if you consider your spinal canal like a straw. Okay, like you can see over here. What stenosis is a kink in the straw. All right, so if you're drinking slowly out of a kink straw, you can drink just fine. You don't even notice that it's there most of the time. Okay, and that's like when someone with spinal stenosis is sitting down or not being active, generally they won't feel much pain. Okay, but when you try to pull fast or drink quickly out of a kink straw, all right, you can't pull as much as you're wanting to. You can't get enough nerve supply as you're trying to get to your body, and that's experienced as pain. And that's pain either in the back, or you can feel tiredness in your legs, or pain going down one leg or the other. Okay, and you can have spinal stenosis in many different regions. Okay, this picture here that I think you can see the arrow that I'm highlighting, is showing your spinal canal, which is right in the center. It can be kinked in the middle, it can be kinked towards the outside, it can be kinked where the nerve is leaving, coming to one leg or the other. So there are many different types of spinal stenosis, not just one. Okay, there's central stenosis, which is right in the middle. Obviously, there's pyramidal stenosis, we call it, which is where the nerve is leaving and going down to your legs, and that's what will give you one-sided pain versus the other. And that's kind of, quick basic rundown of spinal stenosis. Okay, it's very prevalent. Okay, with the number of people who are, here with us today, there are definitely symptomatic people with spinal stenosis, and the incident is just increasing. Okay, because as we age, it will happen. Our spines tend to degenerate as we get older. Okay, people call it degenerative disc disease. Okay, it's not really a disease, it's just part of the aging process. As we get older, our discs will degenerate and can kind of start to cause pressure on our spine and spinal stenosis. Okay, so how do we experience it? So I'm speaking with golfers, professional golfers here. So from my professional golfers, the number one complaint that I hear is, I do fine when I'm golfing. Okay, my worst days are when it's cart path only. So I have to get out of my cart, walk out to the ball, or walk up to the green, and my back or my leg starts to hurt. Okay, the reason for that is when you're standing up straight, okay, you actually extend your spine. Okay, and you start to put pressure on the nerves, okay, you will experience as pain or weakness in your legs, all right? We call it a shopping cart sign in spine care and spine medicine, where people will say, hey, the only way I can get around is if I'm walking and leaning forward on a shopping cart, or pushing my golf bag around feels okay. Uh, it's really the leaning forward that helps you more than actually the pressure on uh, the device that you're using, okay? Sitting down, again, you're taking pressure off your spine and flexing it forward. So it'll generally relieve spinal stenosis mediated pain. Okay. So this is just another depiction of it. Okay. So if you look down here, down to the bottom right, okay, this shows your spine. And when your spine is in extension, as we see, down here, you will decrease the area of your spinal canal and cause kinking in your spinal canal, and you will experience that as pain, okay? When you flex and lean forward, you open up your canal, you get relief in some of your symptoms. All right, so let's get into the injections now. What is an epidural injection, okay? Uh, I always get, is that the same thing you get when you're in labor when we talk about epidural injections? No, not at all, is my answer. The epidural, okay, is not a type of medication, all right? It's not a type of needle, all right? Epidural is a space in your back, okay? And that space envelops your spinal canal and your spinal cord and the nerves, okay? The epidural space is where we do these injections. So people in labor get numbing medicine put into the epidural space to numb their spine and the nerves going towards the baby is, all right? And that's why it's called an epidural, all right? Epidural injections that we do for pain are meant to put anti-inflammatory, a steroid like cortisone, and there's many different types of steroids that we use, but we put these anti-inflammatories around these inflamed nerves into the epidural space. So it's not really as much a numbing as it is an anti-inflammatory. They're done in an office. They're done under X-ray, which is, you can kind of see a cartoon there on the bottom of your screen that guides us into specific areas because they're very targeted injections. They take about 5 to 10 minutes to do under just some local numbing medicine. Generally, people don't require any, deep anesthesia, and we do them very frequently. Okay. And this is just a picture, of the area in my office where, I'm doing epidural injections, where you just come into the office and you get the injection and you go home. Okay. So what is it? Okay. Does it work? Why do we really do it? Okay. What you're doing is you're depositing steroids directly at the site of inflammation. A question I always get is this just a Band-Aid for, my real problem? And no, it's not. The real problem is when you get a disc herniation, it releases these chemical mediators, okay? And these chemical mediators cause inflammation, and they cause irritation of the nerves that are in your back that go down to your legs, okay? So it's not just the mechanical pressing of the nerve that you get from a disc bulge or disc herniation. It's actually the inflammation that it produces, all right? So we're trying to decrease the inflammation around these nerves so that the pain will go away or decrease, all right? Now, MRIs don't always match with people's symptoms. So MRIs are important, but we try to treat people based on their symptoms, all right? So an MRI can't tell me what type of pain that you have. So it's very important to be able to accurately describe the pain you have, to your doctors and your care team when you're seeing them. There's many different types of epidurals, okay? There's epidurals in the low back that go right in the center of the spine, which is this picture you see here that kind of cover multiple different areas, okay? That darkness in the middle of the screen is medication spreading right up the middle. We also do epidurals that target specific nerves. If you have specific nerves that are pinched in specific areas to reduce pressure and inflammation on certain nerves, and that's what you see here is medication spreading around nerves that go down to your legs. Okay, so this is for stenosis that's on one side or the other. You can do epidurals in your neck, in your cervical spine, in your thoracic spine. So not all epidurals are created equal. There's many different types of epidurals. So one thing is, if you're getting an injection like this done, is to really know what it is, what type of injection it is, what type of epidural you're getting done, in case you go to another physician or doctor that tells you, or is asking what you've had done, so they can kind of help move along your care. Okay. They work and they don't work. Okay. So there's mixed results in all of the studies that we've done. All right. Some of the studies are asking, do they ultimately prevent surgery? The answer is, in some people they do, and in some people they don't. Okay. We know that they improve pain, but do they necessarily prevent surgery in the long run? We're not so sure. What we do know is that the complication risk is very low. So after you're doing physical therapy and you try, conservative medications, it is not a bad way to start, okay? Just because of the low risk with a potentially high reward, all right? Other things that we do for the spine that you may have heard of, called Facet Injections, also known as medial branch blocks, for arthritis in the back, for pain, what we call axial pain, which is straight across your back, that doesn't generally go below your buttocks, okay, and down on the leg, okay? It's pain that's worse with moving, okay? Pain with a golf swing that's on one side or the other is very, very common with facet arthritis or arthritis in your back, okay? And you can't have a joint replacement in your spine, all right? There are multiple joints that go all the way up and down your spine on the sides, all right? You can't replace these joints. But what we do in interventional back pain management is we actually see if numbing these joints helps you, okay, by X-ray guided injections. And if it helps you, we move on to something called a radiofrequency ablation or rhizotomy, where you're putting needles on top of these small little nerves that we've blocked, and you actually heat them up, okay? And by heating them up, these nerves break down and will generally give you anywhere from 6 months to 2 years of relief, okay? And that's just because that's how long it takes those little nerves to grow back, okay? This procedure is also done in the office, a very low risk procedure with potentially very, very high reward. All right, now we're going to get into the good stuff. Now we've talked about it, a few of the basic stuff, but we're going to talk about a few procedures, maybe 5 or 6, minimally invasive spine interventions that are out, okay, that we do very commonly, that are studied and have great medical evidence and have provided us this middle ground between physical therapy, injections, and major spine surgery, okay? And, we're luckily, at a point where all these technologies are being developed that allow us to do these spine interventions in the middle, okay? That will hopefully prevent that, big surgeries in the future if we can. They're not necessarily a replacement, but an intermediary step that may stop you from getting to more major spine interventions, all right? So we're going to talk about first a procedure called the MILD procedure. It's a spinal stenosis treatment, okay? MILD is an acronym. It stands for minimally invasive lumbar decompression. It's indicated for spinal stenosis with what's called neurogenic claudication, okay? Neurogenic claudication means pain that becomes worse with activity, like walking, okay? You experience pain into your legs or your low back when you're active, and generally will go away when you're not active, okay? So what does minimally invasive lumbar decompression do here, okay? It's indicated for one thing, really, okay? Spinal stenosis in the center. Remember, we talked about the fact that you can have spinal stenosis in multiple areas, either in the center or out in the sides, along with multiple different causes of spinal stenosis. What we do with the MILD procedure is we use a tiny little incision about the size of the head of a pen, okay? And guided by x-ray, we are able to go in and scrape out this excess tissue, which tends to overgrow in people who have back pain for long-term back pain. And you take this, it's called the ligamentum flavum, okay? We measure it on an MRI. And if it's beyond 2 millimeters, okay, what we'll do is we'll go in, and you can do this at multiple levels all through one incision, and clean out that area and relieve the pressure on the back of the that's coming onto the nerves to relieve the pressure from spinal stenosis. Before this procedure came out, the only thing that you could do beyond epidural injections was something called a laminectomy. Okay, what a laminectomy does inherently is very similar. Is lamina means bone, ectomy means out. So they will go in and they will take this bone back here and remove all of it along with this ligament as well, okay, to relieve the pressure on the spinal stenosis and relieve that central problem, okay. Now, we found that not everybody needs a laminectomy because they can get significant relief without having to remove all of that bone and altering the mechanics of your spine, in the long term. All right. So that is what the mild procedure does. It takes about 30 minutes. It's done under a small amount of sedation, something similar to like what you would have for a colonoscopy, and totally in an outpatient setting, and you go home generally right after it. Okay. This, what we're looking at here, okay, is a depiction. We're looking at the side of the spine, okay, coming in, and we're looking at the spinal stenosis, okay. That green area over there, on the left-hand side is showing that ligament that has overgrown, okay, and it's kinking that straw, kinking that spinal canal. So we use a small tool, okay, to come in under the guidance of x-ray and remove that tissue to restore the spinal canal back to normal without necessarily taking out lots of bone, okay? So the highlights of this, okay, there's a small, tiny little incision, okay? The instruments are very safe. This is a very safe procedure. It carries about the same risk as an epidural, okay? So it's something that I moved to in my practice rather quickly after 1 or 2 epidural injections that haven't worked, all right? We may move on to this if somebody's a candidate, all right? There's no screws, there's no implants. It's not done under general anesthesia. And we're able to constantly see what we're doing by the guidance of live x-ray. And it works, okay? There's studies out there now that, what we're really looking at for spinal stenosis in the center is walking and standing are usually the worst problems. And we found as we studied it, walking distance increases substantially, okay, and standing time as well, okay. And these results are sustained, all right, and people do excellent with this procedure. This is from one of the mild procedures that I did on a patient of mine. On the left-hand side is before we did the decompression. And if you look kind of towards the top of the screen here, here's a needle coming in that's similar to what an epidural needle looks like. And we inject some contrast that allows us to see the spinal canal. And you can see with the injection of contrast here, it stops. All right. So that's where the straw is kinked on this patient. So if you wonder why epidurals don't always work, is because we can't get the medication to the right area. We're putting it here and it all stops, and we can't adequately deliver the cortisone or the steroids to the right area. This is pointing at the level we were going to treat. Now the picture on the other side is showing after we've completed the decompression. I put more contrast in, and now you can see it flowing down the entire spinal canal. We've relieved that kink in the spine through a tiny little incision to restore flow, okay, in the spine. So when should we use it? All right. Obviously, it's not a first choice. Any type of surgery, no matter how minimally invasive, is never a first choice. So we start with the least risk, which is physical therapy, some pain medication, anti-inflammatories, Tylenol. We can do epidurals. and then we can move on to the decompression, okay? And sometimes I'll get asked by my patients, well, what if this doesn't work for me, okay? Worst case scenario, okay? If this doesn't give me the relief I'm looking for. Worst case scenario, we now move on in our algorithm of treating, your back pain and your spinal stenosis, but you haven't jumped to a laminectomy or a fusion, which you can't take back, Now we're going to move on to something called the Vertiflex procedure, okay? Again, a small, minimally invasive surgery that we do in an outpatient manner. The difference between this and the mild, okay, is this procedure is able to treat stenosis in not just the center of your spine, but also on the sides, okay, which we call lateral foraminal stenosis. And this procedure's been around for over 5 years, okay, and the data supports the efficacy that it lasts up to or more than 5 years, okay, which is very similar to the spine surgical data of laminectomies. Their data will generally say, around 5 years is when they'll have to do something else, possibly. So how does it work? All right, we talked about extension worsening your pain when you have spinal stenosis, all right? When you extend your back, you press on the nerves in the back. When you flex forward, you open up the spinal canal and you relieve pressure on the nerves. So what this is a small implant that basically, we call it an extension blocker, okay? It's not a spacer. What it's stopping is, it's stopping the spine from going into that extension mode when you're walking or standing up to limit the pressure on the nerves, all right? You don't feel that blockage of extension because the spine actually works the same way, all right? We haven't altered the mechanics of the spine at all, but it's just blocking the compression of the nerves. And I have a little model here that actually shows, what it looks like and the size of it, okay? This is the Vertiflex implant. And we can see when we walk, I don't know if you can see this or not, I'll try my best here, but I'm extending the spine and you can see the level below will move and the level above will not compress the nerves, okay? And that's really how, this device works. It's not a spacer, some people actually call it. It actually stops compression of nerves, and it can be implanted at more than one level if there is more than one level of pain. So we find that pretty rarely do patients only have just one type of spinal stenosis, meaning just stenosis in the middle or just stenosis on the outside. Usually it's some type of combination of central or, outside, which means lateral stenosis, okay? So this is where, a little ingenious device like this can come into play. And again, as I said before, it's done with a small incision, about 1/2 inch for this device to fit in, guided by X-ray. And there's excellent evidence, okay? So most people, 9 out of 10 people, 90% of people are satisfied when they have this implanted, if it's implanted for the correct indication. There's a significant decrease in opioid use, which is what we talked about before. What our real goals are here is decreasing opioid use with a significant decrease in leg and back pain as well. So this is a proven technique that we're trying to get out there. We're trying to educate people about, because it's definitely an option for many, many, many people. All right, on to the next newer type of procedure, okay? Known as the Minuteman, okay? They call it the Minuteman procedure because it takes under an hour, okay? It's a minimally invasive spinal fusion, okay? What this device does is let us avoid major fusion in people who are either not candidates for major fusion, they don't want 6 to 8 months of downtime, okay? Or too sick to have a fusion, or a major fusion is too dangerous. It's only indicated for people with a 1-level problem, meaning if you would generally need what's called like an L4 to 5 fusion or 3 to 4 one level issues, okay, that would generally require major fusion, we can avoid with this procedure. I'm not going to, get too far into the details because I don't want to, bore everyone, with too much about this, but I'll tell you a little bit about it and who it's indicated for and what it works for. So again, the major one is spinal stenosis, okay? But it also treats degenerated discs, which we kind of briefly touched on, and spondylolisthesis. And what spondylolisthesis is what people refer to as a slip disc, meaning one vertebrae has slipped forward a little bit on the other one, causing spinal stenosis. And in that case, if the spine is unstable, some of these other techniques may not be appropriate or may not work because you need stabilization in the spine. So I'm sorry if this is gory, okay, but this is what a traditional fusion looks like, okay? This is probably just a one-level fusion with a big open incision with rods and screws, going in the spine. Many of you either have had this or know people who have, and some people it's indicated. It's the only thing that you can do if other things aren't an option, okay? There's also a large group of people that we can avoid doing this type of procedure, and that's where, these minimally invasive one-level fusions come in, okay? It's done with a tiny little incision. It's about 1 inch on the side, okay? The reason we make an incision on the side instead of the center of the back is because we avoid all the major structures in the spine when you're coming in from the side, meaning you're not cutting any muscle tissue, you're not cutting any tendons or ligaments in the spine. This procedure generally takes between 45 minutes to an hour under sedation, no general anesthesia once again. Blood loss is usually very minimal and you're going home the same day, okay? Downtime is much less, okay? I generally see people about 2 weeks after this procedure to see how they're doing. I don't use stitches, so there's no stitches to remove. The infection rate is very, very low. And for my golfers, what I recommend staying away for about 4 to 6 weeks just because of the twisting motion associated with golf. And it's really hard with you guys because everybody wants to get back out there very quickly and they're feeling good rather fast. So I'll generally recommend 4 to 6 weeks of no full swinging or light swings at most, okay? So for me, I don't take any type of surgery lightly, all right? So you have to be the right patient to do this on because we want it to work, okay? These are stenosis indications like we've talked about, okay? This same type of spinal stenosis. But people with stenosis on top of degenerative disc disease, okay, are excellent candidates for this because we can restore the height of the disc slightly and take the pressure off the nerves, all right, as well as treating the stenosis at the same time. The spondylolisthesis, as you can see in this picture, on the side, that slippage forward becomes another person who's a candidate for this, with degenerative disc disease associated with spondylolisthesis, okay? Sometimes if we treat with a Minuteman for the degenerative disc disease before spondylolisthesis, we can actually prevent this from happening. Because as those discs start to degenerate, at some point they may start to slip forward, and that's when the problem becomes worse. So we can actually stop this before it happens. All right, so the biggest complaints are, very similar to what we kind of talked about before, spinal stenosis type of complaints. So I don't want to, repeat this. All right, and again, never first option, never, never, never. We start with less invasive non-surgical treatments first before we move on, and we make sure that you're a candidate, before we go ahead and do this. All right. Again, we're coming in from the side. I'm not going to go too much into the procedural details because it may be boring, okay? but it's a safe procedure. I have a model of what it looks like, okay, which is here, all right? So it almost looks like a screw hex nut where we are able to reduce the pressure on the discs, which are up here, and stabilize the spine with these wings, okay, which you can also see in the picture too, which actually clamp on from the outside and stabilize the spine. This is a picture of it, okay. In the middle of that screw is an opening or a window where I actually graft bone in the middle to help that stabilization and fusion happen through that device. All right, let's move on from spinal stenosis, okay? Because not everybody has spinal stenosis. Are we good on time still? I think I'll try to move along here. This Intracept
You're
procedure
fine.
is for degenerative disc disease, okay? Chronic low back pain that doesn't generally go into the legs, all right? Another minimally invasive treatment to chronic low back pain, all right? When people's discs start to degenerate and you lose some of that cushioning in between your spine, the bones known as the vertebrae in between, which are these, okay, will start to get inflamed because there's no more cushioning here. And it used to be ignored. To tell the truth, you see these findings on the MRI, they show the degenerative disc, they show the inflammation in the bones, and we say, well, there's nothing we can really do about that other than fusing the spine, together, which doesn't always help with this kind of pain, all right? The Intracept team, or this Relievant, which is a company that has produced this, we found a nerve called the basivertebral nerve that sits in the center of these bones, okay, in the center of the vertebrae, that makes you feel pain from these degenerative discs. And with this procedure, we can actually go in and permanently burn these nerves, okay, so that they don't come back, so that you don't feel this severe degenerative disc pain. And, I have one patient, many patients who are golfers actually, who come in who have had epidurals, they've had ablations, they've had facet injections, and they continue to have pain. And we get an MRI and we see that they have these degenerative problems. And we go and do this Intracept procedure, and it will significantly reduce the pain associated with that, because nobody's ever treated it before, all right? And they've now avoided major surgery, and, they're back to their regular activities, the next day, okay? There is decades of research on this, before they brought it out. It started in Europe, like everything generally does, all right, in interventional management, and it was studied there. It was shown effective before they brought it to the United States. And it's becoming more and more often used because of the improvements, all right? So this picture is really showing this cycle that people get caught in with, chronic low back pain, all right? People who are candidates for this procedure will generally have low back pain at least for 6 months, okay, and failed everything else, all right? So we always try, again, physical therapy, chiropractics, you definitely try injections. You try to treat the arthritis in the back with ablations. If you failed all of this, if you failed an ablation and it hasn't worked for arthritis in the back, there's no reason to do it again if it didn't provide you relief. You have to move on to something else. You're not stuck in this endless cycle of injections and pain management that aren't helping you. And that's kind of what we're trying to do, with this procedure. So again, this procedure is not for stenosis type of pain, meaning pain going down your legs, okay? This is for pain that's in your back and buttocks, okay? A different type of pain. This is a nerve that doesn't grow back once we burn it, okay? And so this type of procedure you do once and you're done, okay? It's a relatively straightforward procedure, okay? We gain access into that bone, okay, through the guidance of X-ray, once again, which is how we do most of our interventions. and you put a small little probe into there and you ablate or burn that area. The burn takes about 15 minutes for each level. And once it's done, you pull the probe out, nothing is left in the spine. Again, there's no implants with this type of procedure, and we treat all the levels that are affected all at the same time. Okay. The inflammation that I'm talking about that we see on MRI, okay, they're called Modic changes, okay? And if you're seeing my pointer here, you can see a regular disc will look like this, okay? It's plump, there's a lot of cushioning. When you have a degenerated disc, which is what we're looking at, down below here, they're much thinner. And you'll get this white area that you see on MRI. They kind of look like, I call them like lips, okay? And this is showing inflammation that we used to just ignore. There was nothing to do about it. And so a patient like this would be an excellent candidate for the Intercept procedure. So I say that this is simple, okay? Sometimes people ask me, how do you really see what's going on? Well, the techniques we use to visualize inside, okay? We use multiple x-rays at the same time. We're looking at what we're doing live, okay? We can see the inside of the spine with every, millimeter we move these devices, and that's why they're so safe, okay? You don't have to make a big open incision to see inside the spine, We have technology, it's 2022, to allow us to do these things, and, this is how I set up for an Intercept procedure. Okay, so now we're going to talk about what's called the Sacroiliac Joint, okay, the SI joint that you may have heard of, okay. SI joint problems, all right, are generally felt below the belt line, okay, to one side or the other, or both, all right. Again, this is not spinal stenosis. It's a joint where the tailbone, which is the sacrum, comes in contact with the iliac bone, which is part of the outside of the hip, and it makes a long, narrow joint. And people with SI joint problems, this is why I like this picture, will put their hand below their belt line when they're going from sitting to standing up, kind of at the top or mid portion of your buttocks, okay, when you're walking or sitting or standing, okay. It's a very underdiagnosed issue, okay? And the reason that is because it can almost present like pain that's coming from your spine. If you look at these little diagrams, one shows SI joint pain, one on the left, the one on the right shows pain that's coming from a pinched nerve or stenosis, okay? The SI joint pain can be easily overlooked because people will say, oh, this is definitely coming from your back. Let's do some epidurals. Those didn't work. Let's do surgery, okay? And the only way to really diagnose it is with a good physical exam and knowing that there can be other problems, okay, than just the back that will cause issues into the leg. All right, so the diagram over on the right side shows your sacroiliac joint, okay? That little blue dot shows kind of the center of the joint. And the problem with the SI joint is, number one, women are much more likely than men to have sacroiliac joint problems. And the reason for that is this is the sacroiliac joint. This is the birth canal here, okay? This joint is meant to be one piece. The reason it's not one piece is because this birth canal needs to expand, when human beings have babies, all right? And this is part of the birth canal that will expand to allow baby to pass through. So these ligaments will weaken over time, okay? And this joint can become unstable and rub together with what's called micromotion, or tiny, tiny little motions in that joint as it rubs together can cause intense amounts of pain in the low back. All right, men can get the issue too because we have ligaments just like women that connect the sacrum to the ilium, and we can get that micromotion as well and start to have SI joint issues. The number one complaint is sitting to standing or going upstairs. when I get out of my car, it really, really hurts, okay? And you grab kind of your buttocks as you're getting up because it feels a little better, okay? And this is a mechanical problem, all right? So what do we do? Of course, first, before we do any surgery, you try what's called a diagnostic sacroiliac injection, where you put a small amount of numbing medicine and cortisone into that joint to see if we get significant relief and diagnose that as the problem. If there is micromotion, the pain will generally come back within a week or two. All right. So the issue is that joint is not stable. We need to stabilize it. Okay. And the SI joint has been around for a long time, but stabilizing it was always a major surgery. Okay. And until this minimally invasive sacroiliac fusion has come out, there was really only one option. Okay. What this is a small little device. It almost looks like a door shim. Okay. That we put into the SI joint that's made out of bone. It's not metal. There's no screws here. It's made out of bone. And we put a bone graft inside that little window that you see down there at the bottom, which allows the bone to go through there and stabilize that joint permanently without putting screws into the joint. This is a picture, of an actual patient here, okay? And on the right side, you see a traditional sacroiliac fusion, okay, with 3 bars coming from the outside of the hip, okay, which is here, okay, through the bone into the sacroiliac joint on the right side, basically pinching it closed and stabilizing the joint, okay. People don't do too well with that, I find, okay. Now what we're able to do is you see on the other side, if you can, barely see it, I'll show with my mouse pointer here, this is the SI joint stabilization system. The reason it's darker than bone is that we impregnated it with a little bit of contrast so that we can actually see it and differentiate it from bone as we're placing it into the joint. All right. And that actually will stabilize the joint, but in an open position like it should be instead of pinning it closed. There's very fast recovery, again, just under sedation. And, it's a procedure that's being done more and more and more commonly because the sacroiliac joint has become a very prevalent issue, and we're now realizing more than we used to, okay? Again, we start conservatively before you go on to any of this like we do with everything else, all right? Sustained relief, decreased opioids, all what our goals are, okay, with this procedure. Again and again, we don't do this without doing more conservative options first. Kyphoplasty, which is a procedure you may have heard of, okay, is here to treat back fractures, okay, something called compression fractures in the spine, where guided by X-ray, we're able to reduce these fractures, all right, by inserting a balloon into these fractured bones and putting cement in it to almost immediately heal fractures and restore height. This is a procedure that's been around for a long time, but we've perfected the techniques enough that it can now be done in an office-based setting, almost like an injection. It takes about 15 minutes, to do something like this in the office. And this is me here doing one in my office, with a patient who had, an acute compression fracture and was in terrible, terrible pain, who walked right out of my office feeling great. It's a great procedure that can significantly, reduce or eliminate pain for people with back fractures. All right. It's meant for people with compression fractures of the spine, of course. We improve pain and restore some height in the fractured back. All right. The risk of leaving these bones compressed is you'll have an increased risk of pneumonia and blood clots, all right, because there's decreased mobility with these type of fractures, okay? And it's a very generally easily correctable thing, all right? I'm going to briefly talk about this because I know, we're kind of running a little long, and I want to leave some time for questions if we have any. But people have heard of what's called PRP injections, platelet-rich plasma injections, and we could do 2 hours on this, but I'm just going to briefly touch on it because, especially with athletes, it's becoming more and more prevalent and more used. All right. What is it? Okay. It's not a stem cell injection. Okay. PRP is not a stem cell injection, which is sometimes wrongfully, described as. All right. What PRP is you take blood from yourself, okay, about 15 cc's of blood, and you spin it and separate it into what's called plasma and whole blood. Okay. Inside the plasma are platelets, which generally contain not just things that help you clot and stop bleeding. That's what everybody thinks about platelets, but growth factors. Okay. And the growth factors are what help in tissue healing. All right. So what we're doing is increasing the concentration of growth factors directly on an affected site. And I do this on many golfers who have golfer's elbow, which is pain in the center of your elbow. The outside is tennis elbow, the inside is golfer's elbow, and I'm sure many of you have dealt with this, okay? You avoid the negative side effects of steroids over and over again, and people do very well if they have the correct indications for PRP. And this is just an example of me going ahead and doing this on the office. A simple blood draw. The middle picture is what it looks like once it's been separated. That goldish yellowish stuff is the plasma that we separate from the whole blood, and then we use an ultrasound to guide the injection of the plasma into the affected area to resolve the pain or reduce the pain. Now, I am not taking anything away from my surgical colleagues of what they do, okay? What they do is very important, and there's huge use for it, and we definitely need these therapies still, okay? What I mean by all this has happened before is for coronary stenosis, it used to only be open heart surgery was your only answer, okay? Cut open from here to here, open the sternum, and correct, clots in the vessels, okay? In the mid 1980s, first coronary stents were placed, okay, through a tiny little incision in the leg, going up the blood vessels, and we could deploy stents to relieve stenosis in the heart, okay. It dropped open cardiac surgery by about 35 to 40%, okay. Now, of course, there are certain things that we still require open cardiac surgery for, but that step has brought on, a real revolution in the treatment of heart disease, okay? From the stenting, we can now take out clots that are in coronary vessels. We can actually deploy devices that can stop blood clots from going to your lungs. We can replace valves in the heart without doing open heart surgery, okay? We can fix dilated aortas by stenting them without even an incision, okay? So, over the past 30 years, 30 to 40 years, that has, really revolutionized cardiac care. And that's what's happening now with back pain. And we're a little bit behind, but, it's finally happening. And we need to bring this, into more mainstream care, and more people need to start doing this so we can get there and help. Okay? So why is this all important? Okay. Just to kind of sum everything up, we now have minimally invasive techniques that can help us avoid major surgery. All of these things I talked about don't require any hospital stay or general anesthesia, okay? We don't anatomically disrupt the spine in any way. If these procedures don't work or are not indicated, you can always move on to more invasive techniques. It doesn't limit you. And the real most important thing to take home from this lecture is you need to be informed, and you need to make these decisions with your doctors and with your surgeons and know what they're talking about, and really demand that people explain what's going on with you and why they want to do certain things and why one thing is better than the other. And I hope, a lecture like this can at least, touch on the baseline of it. And, we can all, expand and treat care much better as we go forward, especially with the back, among other issues. All right, and that's all I have for you, unless we have any questions here.
Yeah, thank you so much. That was wonderful. I I'll give some time real quick for people to throw some into the chat or the Q&A feature, but there was one I'll call out throughout the presentation, and that was, how much does the golf swing affect back health in general?
So I wouldn't say that the golf swing directly affects your back health. Our back pain and developing arthritis in the back will limit the golf swing, and the golf swing can become more painful because of the rotary movement you're doing, as especially in the lumbar spine, as you're swinging and turning, you're putting pressure on the joints in the back. Okay, it doesn't make your back worse. Okay, it can just become painful, and that's when things like ablations can come in to really limit the pain and allow you to participate uh, uh, in golf or anything that you like to do in general. The rotary movement itself doesn't make you worse. It's just genetics, unfortunately. Okay, as we start to develop arthritis, our back can start to hurt, or degenerative discs, our back starts to hurt, and that's why we have these kind of therapies to allow everybody to continue to participate in golf or whatever makes them happy, because it's not likely to make them worse. It's the pain that's limiting your ability to do that.
And then what percentage of patients involved with more invasive procedures have traumatic spinal cord injuries?
I'm sorry, can you repeat that?
Yeah, what percentage of patients involved with more invasive procedures have traumatic spinal cord injuries?
If we're talking, I'm assuming the question means being caused by the procedure. The incidence is low. Okay, we have they when we're doing these procedures, they're done under what's called neurological monitoring, where they're monitoring nerves while they're doing the procedure. Okay, to limit the chance of major spinal cord injuries. Okay, they're very safe, and those procedures are developing as well. They're revolutionizing their way to do more invasive spinal fusions to limit the chance of injury. So the incidence is low, less than 1% of traumatic, injury to the spine. Okay, but it's not absent. And the reason why procedures like the ones I discussed exist is because once you do that, you can't take it back. Okay, so if it doesn't help you or it makes it worse, there's no going back for it. So you want to be sure that you've done everything you can up until that point, and before you go ahead with taking the risks, that come along with any kind of invasive spinal surgery, and know that you're doing the right thing.
We have another one here. How important is a strong core relative to back pain?
It's the most important thing. Okay. Strong core, and I'm not talking about a six-pack washboard abs. Okay. I'm talking about strengthening the abdominal muscles along with the obliques, which are on the side, and the muscles in the low back. Okay. Toning them these muscles will take pressure off of your spine as you strengthen them. Okay. And reduce the pressure on the discs and really limit the degenerative cascade. So when I have patients that I give a home exercise program to for back pain, it's all centered around toning and core strengthening, things like planking and leg lifts, not necessarily abdominal crunches, because those can worsen your back if you do them incorrectly. I generally advise what I call like around the world leg lifts, where every morning when you wake up, you're lying in your bed and you do one from your back, about 20 leg lifts with either one or both legs, and then you turn onto your side and then go up to the side until you get tired, and then you flip onto your stomach and do leg lifts until you get tired, and then you go to the other side. Okay. And simple thing like that, 5 to 10 minutes a day of stretching and core strengthening can limit or, reduce the reoccurrence of back pain. So when you do something like an epidural injection and reduce inflammation around the spine, the people who get better long term are the ones who continue to exercise and participate, in their own care, knowing that there's a problem uh, in the spine to prevent this inflammation from coming back. So core strengthening is the most important thing that you can do, along with weight loss. Okay, uh, weight loss. Okay, the lumbar spine, your whole life bears the brunt of your entire weight. Okay, so imagine carrying around, 5 to 10 pounds all the time. Okay, and then just dropping that. All right, you're taking a significant amount of weight off of your lumbar spine, and again, preventing that degenerative cascade from happening. So weight loss and core strengthening are the most important. You don't have to be severely overweight to, need some weight loss. Okay, 5 to 10 pounds, which many of us, including myself, say we could lose, and it's important if we can. All right, you don't have to lose 50 pounds to get significant relief in your back pain. Small things, can go great ways in the long term.
Um, how often does spinal stenosis pain change or resolve itself?
Um, that's a difficult question. Everybody's different, and it really depends on what you do. If you do nothing, generally it won't go anywhere. Okay, so it depends on what you do about it, and is it physical therapy? Is it, medications, or is it injections? Okay, uh, all of that we do concomitantly to try to reduce spinal stenosis pain. And what I tell my patients, again, when I talked a little bit about MRIs, it doesn't matter if your MRI says you have spinal stenosis if you have no pain. Okay? It there's been studies done on people in their 40s. Okay, 100 people um, with no back pain whatsoever, and they MRI'd all of their lumbar spines, and 50% of them had some type of spine pathology, whether it's stenosis or degenerated disc. So, although the stenosis may not go away, as long as the pain or the symptoms are resolved, there's nothing really to do about it other than continuing to participate in your own healthcare and wellness, and knowing that there's something there. So it can go away without any type of procedure or injection, as long as you try to do something about it.
All right, Dr. Roufaiel, I'm going to let you go. We do have other questions that I know we're not going to get to, but I feel like we could probably go all day on this topic, especially as it relates to what the majority of the people on this call do for a living. But I will be considerate of your time. I know you've spent more than enough of it with us this morning, but we do appreciate all the time and knowledge you've shared with us. And hopefully
Sure.
everybody will be a little bit more cognizant of what they do to their bodies on a day-to-day basis. And we appreciate the information shared this morning.
Sure. Thanks for having me, Jackie, and everybody. It was an honor to be here. And my email is on that last slide. If you have any questions you want to send me later, I'd be happy to answer anything you have. And thanks again. All right. Have a great day,
Are
everybody.
you?
And a good. Hmm.
Thank you so much. We appreciate, no, never mind. Thank you so much. We appreciate it.
All right. Take care.
And now, everybody, if you would stay on with us just a little longer, we do have a special partner presentation from our friends over at Calgen. Christian, are we out there?
I am here.
Awesome. Well, this is the founder and CEO of Calgen. He's with us this morning to give us information on all that is Calgen and stem cell research. So, Christian, the floor is yours. Thank you.
Thank you so much. So let me start with sharing my screen. Okay, so do you see this, Jackie?
Yes, we see that.
Okay, Okay, so I obviously won't have a whole lot of time to talk about this whole topic here of stem cells. So I'll just touch the key points, but it should give you enough information to see how this can help you in your life. So the topic is endogenous stem cell mobilization, which means the release of your own stem cells. So I will go quick, but if anybody has any question, would like to dig a little bit more, everything that I'll be talking about here is in this book. Before I go into the topic itself, just because I just have a little bit of time to cover a topic that obviously could take so much longer to go into the detail, I just want to start with a video to kind of almost sort of have an impact on your mind. As to the power and the potential of your own stem cells. So this is a work that was done by Dr. Doris Taylor, where she took the heart of a mouse and then digested the entire cardiac tissue with enzymes. So after about 12 hours, the entire tissue is dissolved. So all that you're left with is the soft skeleton of the heart, which is essentially connective tissue that is supporting, again, the soft structure of the heart. Then on that soft structure of the heart, they basically just laid the animal's own stem cells. And we can see within a few weeks, the stem cells do recognize that tissue as being a cardiac tissue. And then you get the reconstitution of a beating heart in a test tube, just to show the power of your own stem cells. This is what your own stem cells can do into your body. So when we talk about stem cell treatment, I know that there was a mention of PRP just before. Maybe we have time to go a little bit into this, but generally speaking, when we talk about stem cell treatments, we talk about stem cells from a source, which can be an umbilical cord, can be your blood, can be your fat tissue, can be your bone marrow. These stem cells then are expanded, meaning multiplied or not. It doesn't have to be. And then they are re-injected into your bloodstream or directly into a tissue or at the entrance of a tissue. But if we look at this from a distance, we see that the stem cells are coming from the blood, the fat tissue, or your own bone marrow. So meaning they are in your body to begin with. And by injecting them in the blood, we actually simply increase the number of stem cells in circulation through an injection. So what has been my focus of research over the past 20 years was that if stem cells have such regenerative potential, and that's the reason why there's such an interest worldwide in stem cells, they're not better because we take them out of the body and put them back in. Given that we do release them naturally from our own bone marrow every day, what about a method that I called endogenous stem cell mobilization, which essentially is the release of your own stem cells? What this can do for tissue repair, and then later on we'll tie this into golf. But right now I just want to speak very generally as to what we can find in the scientific literature about this approach. First, for this approach to mean anything, we need to establish that stem cells are the repair system of the body. So here's a very quick animation that is going to show the natural role of stem cells in the body. So this is basically the accumulation of the past 15 years of research in that field. So the animation shows the heart, but it can be an injury to anything: bone fracture, torn ligament, injury to the skin, doesn't matter. You have an injury, the affected tissue will release compounds that will travel to the bone marrow, and when they reach the bone marrow, they will trigger the release of stem cells from the bone marrow. Within probably about 3 to 5 days after the injury, the number of stem cells in circulation will increase anywhere between 3 to 10 folds. Now, when they are released, the stem cells don't know where to go, so they circulate everywhere in the body. The way for them to identify the tissue that needs repair is that on the second day, that tissue, in this case the heart, will release a number of compounds, but specifically one called stromal derived factor 1, SDF1. That compounds will diffuse locally in the capillaries around the injury, and when stem cells are passing in that capillaries and they get in contact with SDF1, it triggers the migration of these stem cells out of the capillary and then into the tissue. Upon contact with cellular debris of that tissue, stem cells will multiply and will transform into cells of that tissue, literally repairing the tissue. This is your repair system that has been active since the day you were born, anytime that you had an injury. As you probably notice, we don't repair as well as we age, and it's simply because the number of stem cells in circulation declines drastically as we age. Past 30, we are left with maybe 95%, we have lost 90 to 95% of the stem cells that we're born with, and that continues to decline as we age. But in this whole story, the key parameter is exactly that, the number of stem cells that you have available in your circulation to participate to tissue repair. So here is one study to illustrate this concept here. I can use tons of studies in the scientific literature. This one just illustrates this in a simple way. So these are individuals who showed up at the hospital after a stroke, and then the doctors quantified the number of stem cells in their bloodstream, and then a few weeks later separated all these individuals in two groups: people who recovered very well and basically resumed a normal lifestyle, a normal active life, and then the other group who did not recover very well, either passed away or had to go to physical therapy, rehab, to deal with the consequence of the stroke. And we can see that people who had a poor outcome had roughly on average about half the number of stem cells that we find in healthier people. I will not have the time in this presentation to go through to this entire aspect here about stem cells, but it's very interesting to just note that this relationship here of half the number of stem cells in the circulation of people who do not do as good as others is a kind of ratio that holds true in a lot of studies about let's call it aging. All those kinds of diseases that we develop as we age: atherosclerosis, heart disease, diabetes, emphysema, many of those, Parkinson, arthritis. If we take a blood sample in the people who have developed these problems and count the number of stem cells in circulation and compare that to the number of stem cells in circulation of another person of the same age that is healthy, we will see that relationship to stand through in almost every single study. About half the number of stem cells in people who have developed the problem, simply because every day, it's every day that we repair as we age. If every day of our life we have a deficit in the number of stem cells available to repair, then we basically accumulate this deficit as we age, and it develops over time into health problem. But anyway, it's not the point here. Here we want to talk about actual tissue repair in cases of injury. So if more stem cells means that you can repair better, then the question is, if we have a means of increasing the release of stem cells from the bone marrow and increase the number of circulating stem cells, can we help various tissues to repair? I will show you just two examples, two illustrations, again, because of time, but we have the scientific literature has many studies illustrating this phenomenon. So here's with a heart attack. So in mice, scientists triggered a heart attack by making a knot in the coronary artery. Then they removed that knot after the heart attack, let the animal recover. Then they separated the mice in two groups. One group was control, and the other group, they injected these growth factors or cytokines known to trigger the release of stem cells from the bone marrow. They did this for about 8 to 10 days. If we look at the animals, the control group, we can see after about a month, very severe scar tissue in the ventricular wall, no new blood vessels, 17% survival, and the typical signs of cardiomyopathy or heart problem that we see in someone after a heart attack. In the group that released their own stem cells, it was a significant release. We can see a reconstitution of the ventricular wall, new functional blood vessels, 73% survival compared to 17, and almost normalized cardiovascular function. Many studies, it's not the only studies that was done, but just to show, and I'm taking this example of the heart not to make any claim here or make any focus on recovery of the heart, but I'm just picking one of the tissues or organs in the body that is notoriously well known to not repair very well. We have similar studies touching the brain. I will not have a chance to show them today. Here's another example with an injury, which is probably more applicable here to golf or what a lot of you may experience. But in red, we have a typical healing curve or recovery curve. This study was done, I believe, on a cut to the skin, but we have the exact same curve for a fracture, bone fracture, or any kind of injury. We get about 50% recovery after 2 weeks and full recovery after a month. As we age, obviously, this can also slow down. But if we trigger stem cell release from the bone marrow with GCSF, which is a drug known to do this, we get full recovery after three weeks. So we gain essentially 1 week on the recovery. And I will show you a case a little bit later of what we can achieve with natural stem cell mobilizers. But essentially just accelerate the healing process. I can show you similar studies with the benefit of releasing our own stem cells on pancreatic function, on stroke, Parkinson's, spinal cord lesion, liver function, many different kinds of dysfunction in the body. But my point here is just to drive this quick conclusion, which is more stem cells in circulation means that more stem cells are available to participate to the process of tissue repair or day-to-day to help us age while we maintain our health. So anything that we can do to increase stem cells. So what can we do to increase stem cells? And that is the field of research that I've been involved over the past 20 years. It started with me when I was hired to study a blue-green algae, an aquatic botanical that was on the marketplace at the time called Aphanizomen onflos aqua. So we'll call it AFA. And at the time, its main benefits were for inflammation, immune support, and for a sense of increased mental clarity, energy. So we rapidly identified the active compounds supporting these benefits, but we came across a number of cases that we could not explain, cases touching significant improvement of cardiac function, liver function, pancreatic function, lung function, brain function, joints, and we had no explanation how this product could affect various aspects of human health. Around the time we are in early 2000, that the discovery that stem cells from the bone marrow could do what I just showed you before, when that data started to come out in the scientific literature, I thought, what if that plant is working by stimulating the release of our own stem cells? It would explain why people that have problems of the pancreas, well, diabetics, stem cells go into the pancreas. For heart patient, their stem cells go in their heart. For Parkinson patients, stem cells go into their brain, and so on. So we developed an assay, we did that testing, and we discovered that indeed this plant was working by triggering a very transient wave of stem cells in the bloodstream. So a short release of stem cells that peaks after about an hour, goes back to baseline 2-3 hours later. So after discovering what this plant was doing, it was clear to me, at least it was my belief, that it cannot be that there's just one plant that has an effect on stem cells. So we started to ask questions about what other plants are known historically or in remote areas of the world that have been used for a broad variety of health benefits. And we simply study these plants for their effect on stem cells. And then here's another one that we discovered. It's a sea buckthorn berry that comes from the Tibetan plateau. So when it grows in high altitude, it has a very unique biochemistry. So this is the field where we harvested in northern China. But same thing here, we studied that berry for its effect on stem cells. Everything that I'm showing you was published in the peer-reviewed scientific literature. And what we see here is an increase in the number of various types of stem cells in circulation. So because of time here, I'm keeping this short, but we have studied in this way a number of plants, and we have found about a handful of plants that all used alone supports the release of stem cells from the bone marrow and put in the circulation a significant increase in the number of circulating stem cells. So these plants have all been gathered into a product that is called StemRegen. So you take 2 capsules of StemRegen and you will release 5 to 8 million of your stem cells. So an additional 5 to 8 million of your stem cells in circulation. So to give you an idea of what this can do in terms of its impact on health, these are a number of cases that were published in the scientific literature. They were published in a book chapter that we published in 2012. So here are some of these cases. So this is a fellow from South Africa He had 5 heart attacks in a week, was too weak, or his condition was too severe to receive angioplasty. So he was basically put on a heart transplant list. He returned home, in his own words, to die, because he didn't believe that he would make it by the time that they get a heart. In any case, I asked him to mimic how he was at the time, and that is what he showed to me. You walk a few steps, and then he was getting out of breath, chest pain, and then somebody gave him the product that we had launched at the time. This was in 2006. It was a predecessor to StemRegen. He started to feel better. 3 months later, he was called to the hospital. They had a heart for him. When they saw him, how he walked and climbing stairs and everything, they tested him, and he was not normal, but they basically said, for a 65-year-old, if we test anybody on the street, he would be a normal 65-year-old. So this is what he was doing after. So in any case, we're not talking about miracles. We're simply talking about enabling the heart to repair in the way that the heart was designed to repair. This is a study that we have done on congestive heart failure, 6 months consumption of StemRegen, and we can see a 19% improvement in ejection fraction. I believe 30-something% reduction, 12% reduction in natriuretic peptides, which is a marker for cardiac function, and a 34% improvement in the questionnaire that established cardiac function. Again, it does not pertain to golf. I just want to paint the picture of your repair system and how putting more stem cells in circulation helps repair. If I talk about in extreme cases here, spinal cord injury, again, this is not the topic of the presentation or what pertains to you, but we know that spinal cord injury cannot be treated. So if your own stem cells can do something, then it's quite significant. So this is a lady after being pushed out of the car 14 years prior. She can only move her right legs. We ask her to move her left leg. There's no movement. She can move her arm a little bit. This is about 8 months after taking this product, and we can see now movement in both legs. She can bend the knees, both legs. She also have lateral movements in both legs. And we will see in the next video, 2 months after that, so a total of 10 months, what she could do in her bed. Again, just keep in mind, this is somebody that had to ring a bell to be turned in her bed to avoid bed sores. It is not, obviously, it is not a normal life. We're simply talking here about a significant improvement in quality of life. But my main point here to show this is just to show, not as a treatment for spinal cord injury, but just to show this is what your own stem cells can do in your body. So it opens the door here to understand what your own stem cells can do for a series of other types of injuries or any kind of problems when we talk about simple repair of joints, tendon, ligaments, muscles. So she's now able to essentially sit in her own bed, read, eat. Here's another, we talked about wound. This is a study that was done on a soccer team in Madrid, professional soccer team at the beginning of the season. I believe it was in 2012 or 13. The team had 12 players with injuries, soft ankle injury. Soft tissue, injury to the ankle. And we took advantage of the situation, separated these players in 2 groups, paired them with equal injury, 2 players. One group was receiving the traditional treatment for those kinds of injury. The other group was exposed or had available to the same kind of treatment, in addition to taking a plant stem cell enhancers that triggers the release of stem cells. We can see in the control group here, typical process here, about 50% recovery in about 20 days, full recovery in about 4 weeks. But in the group that received the plant-based stem cell enhancer, we were able to gain 1 week in the recovery, and we maintained that week so these players could return to play 1 week before. Here is one case just to show again the impact that it could have on injury. It's an accident of somebody who hit himself with a round saw. So he had about a 15 centimeter, let's say 6 to 8 inches injury, about an inch and a half deep. He was told that he could not put his weight on his leg for something like 4 to 6 weeks, and then another 4 to 6 weeks to walk normally. This is him 8 days later. He took an enormous amount of this, of this plant-based stem cell enhancer, and this is 16 days later. So think about, this is a round saw injury, and look at the fine scar. So it's a product that also helps a lot in cases of recovery from injury. And I will just finish with this short video. This is Desmond Dogan, a next pro golf player who stopped playing after a number of injuries and surgeries. So I met him about 2 years ago. When I met him, some of you may know him. When I met him, he was with a brace and with a cane, and he was not having a very great mobility. He started to take the product, and I saw him about a week ago on the field, and I said, "Why don't you just swing? It looks to me like you can do it." And so this is him about a week ago. So my point here in all of this is that golf is a series of repetitive movements, always affecting the same joint, the same tendon, the same muscle. I'm not a golf expert. My training is just physiology. So these are very, very simple conclusion to draw or observation to make. And it leads to these kinds of injuries. The fact that we play constantly over micro lesions created the last time that we played. It's repetitive injury over old micro lesions, and it just does not get better as we move forward. It's simply here a way to be able, by releasing our own stem cells, to there you go. By releasing our own stem cells to basically allow tissues to repair faster, and over time, basically just to give you not only a better game, but maybe even help you to have a better quality of life. So that's what I wanted to share in the time that I had. Jackie, I hope this was okay. I don't know if you want to open for questions.
No, this was great. Thank you, Christian. We appreciate it. I'm not going to open it for questions just because we have gone significantly over time. Obviously, that was due to the longer presentation beforehand, but I will, if you're okay with it, provide contact information or recap email so those who have questions can reach out.
They can do this. Do you want me to give my email?
I have it, so I'll just email it out.
Perfect.
I do a recap
Perfect.
email. Awesome.
Perfect.
Well, thank you so much, and thank you to everyone for the time this morning.
Thank you.